Hey everybody, this is Erica Meloe, and welcome to podcast episode number 49 of Tough to Treat. Oh my gosh, we have one more until 50. That's crazy. Gosh, time has flown by. Before we get into the episode, both Susan and I really want to thank everybody who's left us a review, testimonial on iTunes, or wherever you've listened to the podcast. We really appreciate it, and I've read all of the reviews on iTunes and such, and your words really mean the world to me, truly. And we both want to thank anybody in advance who has found value with the podcast and would like to leave us a review. That would be fantastic. So on to the episode. So you have a unique episode today in the sense that you have me by myself. Susan, because of scheduling conflict, could not be here today. So I thought I would take this opportunity to talk about some really an interesting topic that I have found, for me at least, has been a game changer, and I mean a game changer in my practice. And what do you do with patients that have plateaued, or they're just not really where they should be, or you need to get them that little extra step? I have found in my practice that it's one of two things. Number one, they could have a secondary issue, which a lot of people do, right? Most people do, especially if the pain has gone on for so long. And secondarily, they could have, or you have had issues with exercise progression. Number one, you have not progressed them appropriately. You've either started out too hard, or you've started out too easy, or you're not using the right exercises for the driver. So for example, if someone has a foot problem, or let's say, for example, I'm going to scratch that. Let's say someone has a hip pain and the foot is the source of the problem. You need to train that foot mostly, right? That's the driver. Why would you work on the hip? That's not the source of the problem. So a lot of people, I think you don't progress the exercise appropriately. It needs to be specific to the driver of the problem. And if a patient has plateaued, and if you are on treating the driver, ultimately, they've either started out too hard or too late. And I will tell you, I have seen this, and it is been a game changer in progressing patients rapidly and getting better outcomes. So I'm going to talk about a couple areas of the body where I have found really key principles have helped me in my exercise progression. So this is going to be about exercise progression and getting better outcomes. Okay, so I hope you enjoy it. Okay, so on to my first patient. There'll be two patients I will be discussing, and the first one is a patient I've talked about before, actually, in episode, I will get you the episode number 10. And it was about a patient of mine who had really consistent right foot pain. So I'm not going to go into her history because the thrust of this podcast is really talking about the different exercise progressions that you would use and what to look for in these types of patients. So if you want some background, just go and re-listen or listen to episode number 10. Briefly, right foot pain, posterior tibialis. I found that her driver was in her thorax. She literally had to carry a lot of weight in her left hand during her performance, and her right foot just could not accommodate to that center of mass change. So, multiple interventions, wasn't getting better until she actually came into my office, and we determined that her thorax was ultimately the driver of her right foot pain. So when you have patients who have, we call them thorax drivers, and I've learned a lot of this with LJ Lee up in Vancouver and Diane Lee, where I have taken the Discover Physio series in 2012, and I've taken a lot of LJ Lee's courses recently up in Vancouver. And the exercise progressions that I've learned, they have just been really a game changer in my practice. So when you have patients who have issues in their thorax, and a lot of people do, there are a lot of connections between the thorax and the foot. They both rotate, right? Thorax rotates, foot rotates. So with this patient, she had a deficit in her pushing her pushing muscles. People who have thorax issues and neck problems, whether they have pain in their thorax or their driver is their thorax, whether they have neck pain or whether their driver is their neck, they have problems pushing. They cannot push. They can pull really well. So they have a problem pushing. Think triceps, right? Think all of your pushing muscles. Think anterior abdominal wall, which was the big issue with this particular patient. So what you want to do with exercise progression, even though she had foot pain, you do not want to make the prime focus of her exercise program geared specifically and directly to her foot. She had that before at another place, working on calf raises, doing footwork, and it made her worse because it wasn't her driver. So once again, if you want to see how we came up, or I came up with, the thorax being her driver, just re-listen to episode 10. So with her, we focus mostly on the thorax. And once again, it's not that the joint is stuck or needs to be manipulated. With people like her who are very hypermobile, and I would say for the majority of patients who have issues in their thorax or their thorax is their driver, it's not a stuck joint unless they've had some severe trauma. It's a loss of control, to be honest. So with her, we start off with a very low load. I break it down into open chain and closed chain, upper extremity, lower extremity, and I learned this a lot up in Vancouver with LJ. So with her, with people who have thorax issues, you want to start them very low. It's my opinion, because they can't push. She can be lifting 25 pounds in her performance, but I got her on the table and had her do like a 2-pound skull crusher tricep extension hook lying position. She could not even control that. So that would be sort of your first exercise you would try. You would do an open chain, work on some of those push muscles, right? Do even a 1 pound or holding a 2-pound weight in their hand, hook lying, skull crushers, tricep extensions. I tend to also have them do some, reverse like flies to sort of get that lateral movement. That could be quite challenging for people who have a thorax issue. I do a lot of that with patients, especially with her. She could control that better, ironically, than doing like a skull crusher or a tricep extension. Then you want to move into, so initially I started out with, once again, listen to the episode 10, giving her basic cues, because it's imagery. Once these people, they've had persistent pain for so long, you need to train a new movement pattern, a new motor pattern. And that is mindful. People need to be mindful, and you need to give them cues. Use some, dance imagery. I think we talked about this in the episode. Eric Franklin has a great book called Dynamic Alignment Through Imagery. And performing artists get it, right? So when I had her at the beginning, when I gave her cue, it was floating, imagining you have balloons in your armpits. And with that cue, she would do all these exercises. So open chain would be tricep extensions, low weight, reverse flies, low weight. Even though her foot hurt, her foot wasn't the driver. So I think we need to sort of make that mindset shift. Then we can move into closed chain, or you can do them simultaneously. It depends on the person. I would have her do basic wall lands, literally standing up and just putting her hands on the wall like a wall land. Literally no push-up, just landing on the wall, and see if she could control it. And she could. Her main issue was open chain work. And you'll find that out very quickly when you work with these patients. So we've got the open chain, once again, tricep extensions, skull crushers. She can do some reverse flies. You can have her go into a closed kinetic chain, have her go into a wall land. Don't be so quick to put these patients into rotational movements or lateral movements. Rotation and lateral, like lateral lunging, things like that. That's very sensitive to the thorax. And people who have issues controlling their thorax generally will have a hard time doing that at the beginning. So if you start them out with rotation and lateral lunges without going through some of these basic exercises first, they will fail. They may feel better, but ultimately they will come back. So you really want to go through these beginning phases early, and they don't have to be there for months or weeks, weeks, 7 days, it just to get the basic motor pattern ingrained in their brain. Okay. As I mentioned earlier, the thorax, people who have drivers in their thorax have abdominal wall deficits, right? So if you want to challenge the abdominal wall in this supine hook-lying position while they have their weights in their hands, she could be holding a 2-pound weight in her right hand, a 2-pound weight in her left hand, and just do one arm out to the side like a reverse fly, but do one arm first. That will surely challenge the abdominal wall, and then drop the left one out as well. I see very common patterns. For example, people who have low back issues, people who have foot issues. The thorax is a big factor. It really is. So I would try these, try assessing your patient and see if they do have some deficits or some weakness or loss of control in their thorax. I bet they do. May not be a primary issue in your patients, but when you do find those patients who have primary issues with loss of control, this will definitely help. Okay? So abdominal wall deficits, you can have her do also in hook lying, supine, like a bilateral arm lift, but alternating, right? 2 pounds. I mean, I would definitely have them hold something. Some people can't do it without weight. They need something in their hand. So 1 or 2 pounds to start, alternating arm lifts with cues, balloons in her armpits. That will challenge abdominal wall as well as challenge thoracic control. They need to know when they're losing control. So that is really why it's very important to establish a cue. As I mentioned before, her cue was balloons in her armpits. So they will know. You'll have to work with these patients to establish that they understand when they're losing control. And it's different for everybody, okay? And that's a whole nother podcast. I'm happy to answer questions on that. But let's assume that the patient can determine when they're losing control. Ultimately, it's going to be hard. I had a patient recently I was doing this with, and she was like, oh my God, my arm is shaking. That's obvious that they're losing control, right? Excuse me. So I think that we need upfront to establish some form of imagery or cueing where they feel that they're not shaking as much, or if they still are shaking, the weight's too heavy. Okay, so let's assume we've established a solid cue. Okay, so moving on with regards to this particular patient, you can progress the weight in supine and open kinetic chain, and that will still challenge anterior abdominal wall. She can be doing skull crushers, flies, alternating bilateral arm lifts. She could even take weights in her hands and just do figure eights, and increasing that weight will seriously challenge the abdominal wall and thoracic control in open chain unloaded, right? So moving on to more closed chain, she was very good with with a wall land, but I wanted to incorporate her feet into the picture. The patient needs to know you are cognizant that they have a foot problem, even though that's not their driver, right? You need to, like we say, feel their pain, so to speak. You need to understand that. And she was on stage all evening and obviously uses her feet. So I started out after the wall lands. I had her do wall lands and then just literally do a teeny mini squat. Straight sagittal plane, right? We're not moving into lunges yet or rotation. So you can have her do wall lands with basically a little teeny arm squat with control. And once again, she was actually pretty okay with that. So examples of other types of closed kinetic chain against the wall, you could put a small, maybe a Swiss ball would be too big, but a smaller ball, maybe 35 centimeters or even smaller, and have her do in a modified plank position on the ball, not arms extended, but in that sort of, like prayer pose, so to speak, elbows flexed and leaning on the on the ball. That will challenge abdominal wall, and then have her do a rollout. Move the ball up and down. That is serious abdominal and serious thoracic control. Okay, she actually did have a problem with this because it was challenging. She was actually putting her arms on a Swiss ball on a wall and then moving it while standing. So that would be definitely your later phase exercise for somebody who has a thorax driver, right? And then what I ended up doing with her as well, and once again, I'm incorporating her feet, okay? once she established good control, you can't just move through these willy-nilly. They need to establish good control, and then you move on, right? So I had her do a wall land with a teeny heel raise. So I've incorporated the feet now. If you listen to the episode 10 where I discuss all of her history and such, I believe that her foot was a secondary driver. And so what you'll find with people is that if you're treating them for, let's say, low back pain or knee pain or foot pain, and they're not progressing the way you want them to progress, or they've plateaued, there is a secondary driver, most likely, or you're just not progressing them appropriately through their exercise progression. With people who have persistent pain, generally, I believe a lot of it's a secondary issue. I didn't really treat her foot, but I incorporated it directly into the exercise program while she was working on her thoracic control. When she had therapy before, when they were treating her foot, she wasn't getting better because, once again, it wasn't the primary issue. So you want to focus on establishing control with the driver, and then you can have her work her foot. So I had her do wall lands with little heel raises, and it was great. She had no problem with that at all. The main issue that she had was the abdominals with the wall ball rollouts, okay? So just to recap, the open chain work that I started off with was tricep extensions, okay, reverse flies. You can do an alternating arm lift, or you can do bilateral arm lift together. That is very challenging open chain. Increasing the weight in those positions will definitely challenge abdominal wall. Using one arm at a time challenges more thorax as well as abdominal wall. You get a little bit of that lateral movement in an unloaded position. Go into closed chain. I went into wall lands, easy for her. Okay, I ended up having her do some wall ball rollouts. That was very hard for her, right? The ball against the wall. I had her do some wall lands with squats, fairly easy. Okay, then I ended up doing wall lands with little heel raises, incorporating the feet. Okay, once again, she definitely had issues with the abdominal profile. Okay, and in her history, she had an overactive oblique muscle, and she just wasn't recruiting her abdominal wall appropriately given the amount of weight that she had to lift in the performance. And her right foot just could not adapt to that significant change in the center of mass. And ultimately, that was her buckle point. Okay. So at this point, you want to start challenging a bit more rotation. I mean, you can do squatting, you can do, narrow stance, wide stance. She didn't have a problem with that. So I did not really push that on her. You can have them do a squat, narrow stance, wide stance. That would be closed chain feet, lower extremity. Have them put 1 or 2 pounds in their hands and do an alternating arm lift with a squat. That challenges thoracic control as well as works on sagittal plane squatting, right? I didn't do a ton of that with her because she was okay generally with that. It was ironically the unloaded open chain work, challenging the abdomen and the stuff against the wall, that was more challenging for her. But I wanted just to give you an idea of a progression. So now at this point, we're ready. This was probably about, I would say, the early exercises she probably spent about 7 to 10 days in. And then the significant second tier exercises, I don't know, 2-3 weeks. I've treated her a while ago. I have to go back and look. And then these last exercises, everybody's different because they need to be able to establish control in prior exercises. And I mean, she's back working at the time, and she was lifting all of this weight. And so I had to manage that too. I had to get her back in occasionally, and I was taping her, her thorax to get more control. And you can listen to the episode 10 to as I discussed that. So it is really important because she still was in the show, and she wasn't really capable of lifting 25 pounds without compensating, to be honest. So we had to work a little bit with that. So this last phase, what I ended up doing with her, this is where I introduced the rotation and the lateral work. So the rotational work could be straightforward. It could be as simple as just doing a bow and arrow move, right? Hands in front, move that one arm back and do a bow and arrow. That definitely challenges rotation. If you want to challenge abdominal wall, which is what I did with her, put 1 or 2 pound weights in their hand, right? Really important to do to establish what's their major deficit. Is it triceps? Is it abdominals, etc.? So I had her do some bow and arrows, which she really loved. And when she got flared up, we had her go into some decompressive poses for the thorax. I'm not going to talk about that on the podcast, but for her it was child's pose and down dog. It's decompressive. That really helped her quite a bit. We call it a reset. If you've listened to our podcast, you know that Susan and I talk a lot about reset exercises, and hers was down dog child's pose. If she did an exercise and it flared her up, it usually never did, to be honest. Going back into the work environment and carrying 25-pound weight in her left hand flared her up occasionally. So she would do child's pose, down dog. It would make her feel better. Okay? So then I ended up, after bow and arrow, I had her start to do some lateral lunges. And she was a little nervous with that because that's foot. That's challenging for the foot. Challenging for the foot, challenging for the thorax. They're both rotational joints. So with her, she was a little nervous, and so I had her do very teeny mini lunges, side mini lunges, and then I progressed her to full lunge. So that would be your progression. I did bow and arrow. I did some side lunges. Could I have had her do split squats, standing lunges with rotation? Absolutely. I could have had her go into a split squat or a mini lunge position, put 2-pound weight in both or a 5-pound weight in her hands, and literally do some teeny rotation. I didn't. But that's definitely a progression that I could have done with her, okay? And another great one that I really like is you sort of get into this sort of, you're not in a lunge, but you're in a stride stance and your knees are a little bit bent, and you're doing like a PNF, like pulley cable. So I'm just using my right hand here. My left leg is in front, my right hand's above my head. I'm pulling on a cable above my head or a TheraBand into that PNF pattern going across my body. That is a great exercise and an advanced exercise for thoracic control. Okay, so we're standing, left leg in front, right arm out, and I'm pulling across my body into left rotation. And then what we could do, you would switch positions, right leg in front, left leg behind, switch arms, and do the same thing. There are other progressions of that, but that's a great way to incorporate upper extremity rotation with the foot. And obviously ADLs, we walk and stand all day. So a lot of these patients, even though they look good on the table, when they stand, they don't look so good. So you need to train closed chain no matter what their driver. If they have a neck drive, you need to train a squat. You do. So that's, once again, that's another podcast. So ultimately with her, we ended up really working on the lateral movement and the abdominal wall, which was the thrust of her program, because her abdomen was over recruiting. It was a significant muscle imbalance. Did she have tricep weakness? Yeah, a little bit. But I think it was mostly her abdominal wall profile that was really, really tough. So that is pretty much it for her. I will... what you could also do, just in this in this particular, in this last phase of exercises, you could have somebody go into a full, if they have a problem with closed chain work, which she did not. You could have them do like a modified, like get their feet up on a bench and do a modified down dog, and really work on rotation or planking in that position. You could have them, if you're into yoga, you could have them, do some triangle or some rotational poses there as well. If you enjoy doing that, you could also have her do in Pilates, have her do some seated, roll downs with rotation. I did not with her. Okay, she did not have access to Pilates equipment, and I felt that she needed to do things on her own, as well as she was not into yoga. So I didn't do a lot of that with her, to be honest, but you certainly could. And as a matter of fact, there's Diane Lee just wrote a great book on, it's called The Thorax, and there's a lot of great exercise progressions in the back of that book as well for thoracic, thoracolumbar, and thoracopelvic control. Okay, so now just to recap, you're going to do open chain, triceps, reverse flies. You can do alternating bilateral arm lifts. And then we move into closed chain, wall lands, wall ball rollouts, etc., heel raises with wall lands, then to rotation, bow and arrow. We can do lateral lunges. We can do the pulley cable in that split stance position. There's many things you can do. But that's pretty much what I did with her. And she did great. She did a great job. So I'm going to move on to my next patient. So on to the foot. I'm not going to talk about specific patients per se with foot progressions, but a clinical pattern that I have seen, and one is actually in my book. It's a patient of mine who's a physio. She had a lot of pelvic girdle pain, and it turns out that her foot was the source of her problem. And because she couldn't run, she couldn't really push off well. And I'm seeing somebody now who's got some issues in her hip and her pelvis externally, some pelvic girdle pain and some hip pain. And her driver is her foot. So I'm seeing these relationships. I mean, people who have foot pain could have drivers in their feet. A lot of them do, actually. So any patient where you find or have found that the foot is the prime source of the problem is really who I am addressing with this exercise progression. So I think a lot of people with patients who have foot drivers, they tend to go right into standing heel raises, and it seems logical, right? But it's a very high load and a high level activity for someone who has pain in their foot. And the big thing with foot, I mean, we assess the foot. Everybody assesses the foot differently. We've learned in school, we've learned on courses. I certainly have changed how I assess the foot. I assess it in standing, I assess it in sitting. And that's a different podcast. But I think that the main issues when you have somebody who has a problem in their foot and their driver is their foot, or if they have a problem in their pelvis or hip or knee or wherever, and the driver is the foot, that you really want to put them through different tiers or phases of exercise progression. And the first thing that I generally do, as with the thorax, I do look in to see if tape will help support them, because a lot of times it's not about releasing certain muscles in the foot. Sometimes it is. You have someone who has a really rigid foot. You want to release some of those muscles at the bottom of the foot, the intrinsics and things like that. But most of the time it's foot control. Once you do your release and you can do some joint mobs, depending on the patient's presentation, a lot of it is foot control. Are they pushing off on their forefoot, without a twist in their foot, without inverting the foot and loading that posterior tib? Are they able to get that first ray down? Can they get that first NTP to the ground? A lot of people can't. Interestingly, right? So I think that the main issue is when you're looking at the foot, you want, depending on what their activity is, if someone is squatting, you pretty much know what the foot does when a person squats down, right? The foot should fan, all the toes should be on the ground, the talus should seat posteriorly, the rear foot should drop. I mean, I'm being very general, right? But if someone is squatting and that foot is still rigid, or they're offloading that foot for some reason because of an ankle fracture, that foot probably needs to be assessed, right? So if the foot is the issue, and control is the issue to start with, because you have a lot of patients who have, they're you can just see them. They have really poor arch support. They have a lot of strain on their posterior tibialis. It's affecting their hip. They've got that whole internal rotation torque of their lower limb. Those people, after you've assessed them and you've determined that the foot is the problem, may need some foot control. I have one foot it's like my own body part. I have a foot that really needs control, and one is that's really, really rigid. Okay, so and that's why it's very hard for me to fit shoes, because my feet are so different. So with the first phase in foot control is, I always give patients really easy, heel toe walking, forward walking. Like with my earlier patient, she had been given heel raises for people thought that was her foot that was the driver of her problem, and it made her worse. So I don't give people standing heel raises, so not until later. So I have them do early sort of heel toe, very easy foot control. It's very basic, but effective, because people don't really look at how they're walking. They don't imagine, with the cue. With patients who have foot drivers, my cue for them a lot of is, imagine, you have yoga toes. Your feet are grounded to the earth. It just depends on the person, and you need to find a cue that works for them. But I like yoga toes. Imagine you've got equal pressure on all of your toes. Imagine your feet are rooted to the ground. That's a good one. And so I start them off with heel toe walking. And then I actually have them walk backwards, toe heel, and that's where you really see a lot. And these are basic exercises, but a lot of people cannot walk backwards. I mean, in a straight pattern. And once again, there are many people who walk backwards and walk backwards horribly, but their foot's not the problem, so you wouldn't focus on that, right? And once again, this is for people who have foot drivers. So heel-toe walking is early, basic, 2 minutes. And then I have them do a little bit toe-heel walking backwards, okay? The main deficits that I find in foot control, a lot of it has to do with the rear foot. They've got a rigid rear foot and a hypermobile forefoot. Or they just can't get that big toe down to the ground because of some movement pattern, some persistent movement pattern. I will also have them do some seated heel raises really early, right? So talking about, squatting, when you squat down, once again, you're supposed to, the foot, what we call it fans, right? It splays. When you come up from the squat, it folds. So when someone's doing a seated heel raise and they're lifting their heels, you don't want them inverting that foot, right? That's non-optimal. They may feel okay doing it in sitting, but when they start to run or do whatever their activity is that they want to get better at, they're going to fall back into that motor pattern. And over time, something will buckle. And it obviously has since they're in your office. So the early seated heel raise is nice and easy halfway. Once again, they're going to move through these very quickly because these are basic. And once again, you want to have them use their cue. So then what I end up doing, and a lot of times, if they're not getting the cue for the foot, I'll have them just imagine, almost like space cues, if that makes any sense. I have them put a dumbbell on the bottom of their foot or a ball to release. Sometimes releasing the bottom of the foot helps them splay the foot better. It helps them imagine they have space in between their toes. A little bit of release on a foot goes a long way, especially for people who walk. I mean, I'm in New York City. We walk everywhere. So I see a lot of foot problems here. So the heel-toe walking, the toe-heel walking, and the seated heel raise, I give pretty early, okay? And once again, they can stand up and they can feel pretty quickly if they're equal weight bearing on the right and the left. And if someone has a foot driver, my guess is they're generally off in their center of mass. Once again, it may not be relevant to their problem, but I see it very commonly because one foot cannot adapt and the other foot can. So then after those basic exercises, I don't even want to call them exercises because I would say movement progressions, because they are focusing on movement and really trying to get that heel up without inverting the foot, getting that big toe down. And this is more mindful work than actual, I would say, exertion. A lot of it's really focusing on the placement of the foot and avoiding certain movement patterns, like in sitting, with that extra inversion at the top of the heel raise. So then what I also do, I kind of move through that very quickly. And then what I'll do is I'll give them a squat, because I think squats are pretty straightforward. And once again, sagittal plane, as I mentioned in the last bit about the thorax, side-to-side movement for a foot is something I would not introduce early on, because it is very challenging for a foot as the primary issue. So I will have them do basic squats, right? Pretty straightforward. And then I'll have them move into like a split squat, depending, with one foot back and the other foot forward. I'll have them do some basic split squats, depending on what foot is the problem. If it's the leading leg or the back leg, I'll cue some push off with the back leg, or a little bit more as they're lunging forward with that front leg, a little bit more, fanning of the foot. It depends on what the issue is. And with regards to taping, I do fairly tape. I tape the foot a lot. And people who listen to the podcast, I tape a lot. I tape with Leukotape and Hypofix. I mentioned this taping quite a bit on the podcast. It's called a subtalar joint neutral or subtalar joint gapping distraction technique. I learned this up with Elja and Diane up in Vancouver, and it's a medial calcaneal distraction. I believe there's a picture on our website. If not, we'll have to get it up. There's definitely one in my book, and if not, if you don't have the book, I can probably post a video on our site just showing you how to do it. I just basically take the piece of Hypafix and pull down gently, distracting the calcaneus, and literally just bring it across to the other side. And I put up same thing with the leukotape. And I have found that people who have really rigid foot type tend to benefit from this because that rear foot is so stiff. And they've got so many muscle vectors that are in that posterior medial part of the subtalar joint that really prevent them from achieving good foot control. So I do a lot of release in the foot, and then I'll tape it, and then I'll put them through these progressions. So now we've done the heel toe, the toe heel, we've done seated heel raises, we've done some squats, and now I would have them do the split squat, as I just mentioned, 1 foot in front, 1 foot in back, and depending if they have other issues, you can have them do anything, upper body. You can have them, put a weight in their hand while doing the split squat, depending on what their activity is that they want to get back to. The two people I'm treating with their pelvic issues, they're both runners. So they want to run. So I'm focusing really on the lower extremity and the foot because that's the main source of the problem for their pelvic girdle pain. So we're focusing on, the fanning and the folding of the foot, doing the backwards walking. And so this is when I would move into some heel raises, sort of mid to late exercise progression. I would have them do heel raises against a wall, facing the wall with their knees flexed, or they can turn around with their back to the wall, doing a teeny squat position, knees flexed, and go up on their toes. That's very difficult. A lot of patients tend to invert at the top. So they either can face the wall, fingertip touch on the wall, knees bent, and just raise and lower the heels, or turn around and have their back to the wall and raise and lower their heels with their knees flexed. That's a tough exercise. That's probably a later exercise, actually, now that I'm thinking about it. That's not easy to do. That's actually a lot harder than just standing and doing heel raises. So I would do heel raises, standing heel raises before I did that one, okay? And then what I would end up doing at this point is I would start going into lateral lunges. Honestly, I think with the thorax, I did it a bit later. With the foot, I would probably do it a tad earlier, okay? Just because it's, especially with runners, you really want to, even though they don't run laterally, it's important to get that control laterally because they do rotate their thorax when they run. So once again, to recap, heel toe walking early, backwards toe heel, so walking backwards toe heel, that's early, sitting heel raises early. And then I would move into straight squat, cueing the fanning and the folding. And then I would start doing a split squat, depending on what their issue is, cueing the front leg or cueing the back leg. That's quite important. And then I would start with doing some, if you want to add some upper body pulleys or upper body work in that split squat, that standing position, you can, depending on what activity they want to get back to. You could have them start doing walking lunges as well. Then I would start doing lateral lunges. You're going to start to do that rotational lateral lunge position. That's moving laterally is also rotating in my brain. So lateral lunges, and then I would probably add the heel raises against the wall with the knees flexed that I had mentioned earlier. You could also start having them do rotation in a lunge position. Great for runners. Having them rotate over the leading leg down the track or just down, in the hallway or at home. Really important to start doing that. If you're working with a runner and they have a foot issue, you need to start doing some rotation in the lunge position and really cueing that foot and releasing the foot as well. That's a big thing. Then what I like to do is I like to add some perturbations and, doing some rocker board, Bosu ball squatting, things like that. That would be somewhat later on. If you want to start doing some plyometrics, lateral, double, single leg hops, that's okay. I don't do that until very, very late because that's not something that I do early on with the foot driver. You can also want, if the person likes, a lot of people just don't like to jump, okay, even though they're runners. I sometimes I'll throw in the lateral lunge exercise that I do. I'll have them wrap a TheraBand around their ankles. These are very common exercises that we use as therapists. The key here is really just the progression. You just don't want to start somebody doing a lateral lunge or lunging in rotation when they really can't control their foot or it's just too rigid. They can't accommodate to the forces on the ground. You really want to work on the progression. That was the purpose of this podcast, to talk about progressions in the thorax and progressions in the foot that will get you better outcomes, right? You start with early exercises, like I mentioned, heel, toe, toe, heel, seated heel raises, then move into some squatting and things I had mentioned before, and start doing those before you start to do full lunges with rotation, full, single leg balance on a Bosu ball. That's hard. You don't start those people there. People may say, yeah, I can do that, but they're compensating somewhere else. Trust me. I've seen it so many times. And then there's many other things you can do for people who have problems with their feet, who are foot drivers. It just depends on the activity they want to get back to. If they just want to walk down the street, you're going to modify this program. You're not going to have them hopping, right? If they're 75 and they have a foot problem, you're not going to have them hopping. But if they're 29 and they're a track runner, yeah, you absolutely need to have them hopping. But that would be way, way later on, okay? And I do tape throughout this because I do believe the tape helps, but it's going to be a point where I stop the tape, and that's usually when they can achieve good control, usually mid-level exercise. In the middle of the program, I generally would stop taping. And that is it for my foot. My foot people. Is anything else? I'm just thinking here, looking at my notes about the foot that would be helpful for you. I think the purpose really of the exercise progressions is, number one, is you really want to train the control and endurance of a new pattern. In that early phase exercise. You want to just train it. If they're doing heel raises, things are too difficult for them, or lateral lunges, you can't train appropriately. You need to train the brain. You need to train it in a low-level activity and train the endurance. And then, these mid-level exercises are really, you're what's the word? You want to focus on the building blocks or the foundation for more complex movements and loading patterns, because they will have those, right? And those are important. You really want to maintain neutral. That's why we don't do, within the case of the thorax and the foot, lateral lunges or rotation until the later phases, because those are high level, right? They're 3D. They're multiplanar movements. And so in that later phase, you're going to want to incorporate increased, difficult activity with speed and power, and enable them to have confidence that they can control their foot. That's why there's so many exercises you can do for the foot, but the key, as well as the thorax, but the key is, why are you doing it and when are you doing it? So starting off with a standing heel raise and a lunge and rotation is probably not the best thing. But if you're 4 to 5 weeks in and you're having them still do seated heel raises, you need to move these people and progress them. So I hope that helped. It was my first time doing a podcast on my own. Oh my God. It's hard doing it on your own. So I will welcome Susan back on our next podcast. And once again, thanks a million for listening, and we'll see you on the next episode. Bye.